So my name's Dr Emma Tiffin and I'm a Cambridgeshire GP and I'm Cambridgeshire and Peterborough STP Clinical Mental Health Lead and also a National Advisor for the Community Health and Primary Care Programme for NHS England. And today I'm going to talk through a model that we have created and developed in order to support annual health checks for patients with serious mental illness and also medical monitoring of patients that have mild to moderate eating disorders. So it's a combined role. And we actually call this role Specialist Healthcare Assistant on the back of a lot of consultation that we did with our service users and carers about what they felt the name of the role should be. And finally, just to emphasise, this is a one-year pilot at the moment, so we are looking at what works, what doesn't, and we can still tweak the model. And I'm going to now talk about that, but as I say, it's possible that it may change slightly, and certainly we may, if things don't work, we will obviously make amendments and change it. So just briefly, how are we focusing on both serious mental illness and eating disorder patients? I mean, we know that serious mental illness patients have a high risk of physical health conditions, die sadly on average 15 to 20 years earlier, with a 3 times higher death rate for patients who are under 75. We also know that 2 in 3 deaths are from preventable physical illnesses. And you can see the major causes of death there being cardiovascular, respiratory disease, diabetes, hypertension. And a final fact I think it's important for us to be aware of at this time is that very sadly SMI patients have been massively impacted by COVID and actually have higher mortality rates than patients without SMI. So we're very keen to change that and make sure that we have the best possible physical health for our SMI patients locally. And in terms of eating disorders, those patients have the highest mortality from any psychiatric disorder. And we have been looking at how we put in place a really safe system for medical monitoring, which also fits with national guidance. In terms of our CCG, you can see that we're almost 1 million in terms of population, so we're a large CCG. Our serious mental illness register is 6,516 after validation, so that means it's as accurate as we can get it, and we've removed patients from the register that aren't actually serious mental illness, so we have cleansed the register. In terms of eating disorder medical monitoring, you can see that the number is very small, which is partly why we've combined this role, and we are thinking about whether we will add other conditions or mental health, physical health monitoring needs into the role longer term. But at the moment, we're just starting out, so that's not the case. So our proposal, which we've made a start and actually launched, is to host trained specialist healthcare assistants within our GP federations. And I think that's where this is quite novel and we hope an example of best practice. So as I say, these trained HCAs deliver annual SMI physical health checks. And I will talk a little bit more about that in a minute. In terms of the eating disorder medical monitoring, that is undertaken for moderate, stable, engaged patients, and actually the results are managed within the specialist eating disorder service. And what we've put in place to support GPs and primary care in terms of the eating disorder medical monitoring is a daily GP helpline. We've got a GP employed within the specialist service to broker both strategic and operational function, really to broker the relationship with the GPs, as well as actually help manage patients within the specialist service. And just in terms of the overall management of these specialist HCAs, the operational management is provided by the GP Federation, which really we feel gives primary care ownership. And it's really important that primary care mental health, is owned by both GPs and by the mental health team. So we're trying to really fill that space and make sure, as I say, there's a true joint ownership and vision for primary care mental health. And the clinical supervision is provided by the specialist service. And that is the same for the serious mental illness function, that the clinical supervision and training is provided by our primary care mental health service. So what are the benefits? Intensive support to promote engagement. So these staff actually phone patients up. If that's how they want to be contacted, they might send a letter as well, they might send a text. So it's a very proactive approach to ensure that patients come in for their checks where at all possible. Patients are receive their checks in the local primary care setting. That's really key. We know that serious mental illness patients will say that it's very important to them to go to somewhere familiar for their checks. They don't want to go to, for example, a mental health establishment. They want to go to their local GP, and also continuity. So that's what patients are familiar with. And again, for SMI patients, that's really important, is that continuity. Also supports patient access and choice. So we've done a lot of patient feedback, carer feedback, and the overall message is, you know, we do want to be able to go where we want to go for our checks, which as previously, you know, is very often primary care, the GP setting. And promoting parity of esteem. So we don't want, you know, primary care is where we see patients with both physical and mental health needs, and we want to continue to encourage that. Quality, I think, is a big one here. So traditionally, the physical health checks have often been done by unqualified staff in terms of mental health within GP practices. So these staff are specifically trained to know how to best engage patients with a mental health need. So that can vary, but very often there needs to be more work done around reassurance, around giving information in understandable ways, for example, motivational therapy as well in terms of accessing interventions. So one of our big aims is to not only do the checks, but more importantly, support patients to access physical health interventions, such as stop smoking, weight management advice, because that's what will make the difference to outcomes, which to date we haven't managed to change. So, you know, we want to improve radically this gap of 15 to 20 years, which I still think is shocking in terms of, you know, sadly, when SMI patients' mortality rates. So it supports joint working, so the staff are actually based within primary care, but as we said, have their training in secondary care, so that, you know, we hope will support true joint working and not just pay lip service to it. And clear discharge plan. So again, in terms of the eating disorder patients, you know, they will be discharged with a clear plan around the monitoring and fast access, as I referred to previously, to specialist advice or reassessment if required. Our model actually follows national guidance. So with eating disorders, mild to moderate patients, it's recommended that those patients are monitored in primary care where possible and where the patient chooses to do that, whereas severe high-risk patients are monitored within the specialist service. Specialist BAME workers, we've actually got a function within the staffing to ensure that each worker focuses on a minority group, which would include the ethnic minorities. And we have actually got our first service up and running in Peterborough, where we have a large ethnic minority population. We have 6 big groups, so each of the staff focuses on different groups, so they have a specific remit around those groups in addition to their general work. And what the staff also do was support patients to attend other long-term condition health checks. So we know that patients have a higher rate of asthma, say diabetes, heart disease. So not only will the staff do the check, but actually support patients to access, for example, their diabetic check, their asthma check, if it's identified that that's a need for that patient. And we want to also upskill the workforce in both serious mental illness and eating disorder across our system. So because these staff are employed by our GP federations, the GP federation also has healthcare assistants that carry out more generic roles. So by virtue of them being the same cohort and overlap and the same building, you know, we want to make sure that we upskill the generic healthcare assistants in mental health skills in addition, and also the primary care teams as well. So we launched the SMI health check function and our first staff at the beginning of November. And I haven't got a slide on this, but the outcome is really good. So far the uptake is 70%, which is fantastic. Compared to previously, we were pottering along at about 43%, which was nowhere near good enough. So that 70% of physical health checks for our SMI population have been achieved in the practices where the staff, the specialist healthcare assistants, are in place. So we're hoping that that will continue and we can feedback more as we get more results from our evaluation. We're also engaging our other 2 GP federations, so that's our Fenland, the middle of our patch of Cambridgeshire, and also Cambridge. Again, very, very good engagement with the management teams. So we're planning on rolling out in April this year, with the only caveat that, of course, COVID is making things a bit more difficult in terms of redeployments than we'd anticipated. But that's still the plan at the moment. And as I say, we are doing an ongoing evaluation. So for primary care, just to summarise really, we're aiming for 80% of physical health checks to be achieved. I'll comment on the figure previously of 70%. It's interesting that the other 30% tend to be patients that just weren't contactable at all. And in Peterborough, there's a huge turnover. A lot of patients go back to their own countries and we don't know that. So we suspect that that accounts for a lot of the 30%. So in reality, the figure would be higher if we didn't have a huge turnover of patient lists, which is what Peterborough specifically has. The checks are 45 minutes each, so quite an extended period of time. Feedback from our staff so far is that that's about right. They also are able to offer 20-minute follow-up appointments to support access to other services. So again, moving away from just the signposting to actually supported access. So the staff will go with the patient, say, to the stop smoking service appointment if that's what the patient wants, or help them organise that appointment, or whatever that patient needs to really encourage them to attend. There's also robust pathways with our voluntary sector and our community resources. So again, they're linking with some other elements of our community mental health transformation around particularly a very interactive community resource called How Are You Peterborough. Bearing in mind at the moment these staff are just in Peterborough, and that involves Facebook, a website, which is a really interactive resource where people can actually click on their area and find out at the click of a button what is available to help them, not just in terms of health, but community resources. So it might be yoga, might be Pilates, it might be a local gym. And the other difference with that resource is that there are videos of each service. So rather than, again, just names, numbers, we actually ask the services to put videos on so that our patients can see what it would be like to, say, go to a yoga class, what it's like to go to their local GP's surgery, what to expect. So that's a little bit different too. We are able to offer home visits with the service, again, which is quite different than is very often the case, both for eating disorder patients and for serious mental illness. And as I said, there's actually a GP within the eating disorder service who's supporting the primary care, secondary care relationship. And in terms of vaccinations, very important to mention vaccinations as well as actually, I think, screening for cancer screening. So the staff encourage and are now training to give the immunisations. Of course, the current ones are flu and COVID immunisations. So again, we have the benefit of staff that know the patients, that are able to spend time with the patients, explain what's involved, address queries, which we hope will increase the uptake of both flu and of COVID immunisations. So we will be able to report with a little bit more time on those as well. But there's a big focus on giving and encouraging immunisations. And the other point there is back to cancer screening, that again, there's one of their roles, functions is about really supporting patients to access, say, cervical screening, mammograms, bowel cancer screening, depending on the patient's age and where they are in the screening, in the national screening programme criteria, so whether they're eligible. So where they are eligible, that's also encouraged, and again, these staff can support patients to actually access those screening investigations. On the right, you can see the core elements of the serious mental illness health check, and below that you can see the added elements that we include in our check. So again, one thing just to highlight here would be around medicines. Huge safety issue for serious mental illness patients, really, really important to get this right. Antipsychotics, for example, have a massive risk attached with them, which if we're not careful on the monitoring, so increased risk of diabetes, metabolic dysfunction, heart disease. So in terms of the actual physical health check of the specialist healthcare assistants, after they've done the check, there will be a notification that goes through to the GP to look at the medications, review the medications, and potentially involve the practice pharmacist in a medication review. And they will also check that the monitoring is up to date, depending on what medications that patient's taking. So I think I've covered most things. As I say, we're up and running in Peterborough, and we're now looking to extend to our other GP federations. You can see the model here, which just describes the process of our SMI physical health checks. Very important to actually cleanse the register before you start, because we do have some redundant, what we call read codes on the system, on the computer system, and they need to be checked so that we don't invite the wrong patients in for a check. You can see it's quite a proactive process. We don't just give up when people don't turn up, they are followed up. And there's also a process in place if there are mental health issues identified, whereby that patient can be supported to access further mental health intervention. And the eating disorders, again, you can see the process here. Just in terms of the primary care service, it is for mild, moderate, stable, engaged patients. And as I say, the unusual thing in many ways is that we actually have the specialist service review the results, which just means there's a lot of queries around safety and competence in reviewing results, a lot of nervousness in primary care. So that's how we've overcome and monitored that into our pathway. And as I say, it's very much integrated. For patients that are completely discharged of primary care from the eating disorder service, then the GP will pick up all the results, however, in that circumstance. So that's it. It's a bit of a lightning run through, and happy to take any questions, as I would usually say.